Hi guys, my name is Sharon. I did a quality assurance case study report of a carotid artery exam that I performed on a 74-year-old female patient with bilateral bruise in her neck, which were found by her primary physician during an exam. While taking her history, I found that she was a former smoker. She had hypertension, hyperlipidemia, and a family history of stroke. She also reported transient blurred vision, but no clear amaurosis and atypical symptoms, including a warming sensation in her chest that rose up into her neck and through her left arm. While performing the ultrasound exam, I noted diffuse, irregular, heterogeneous plaque within the bilateral common carotid arteries, and also large formations of irregular heterogeneous plaque in the bilateral proximal internal carotid arteries with velocities of 331 over 123 in the right and 456 over 184 in the left. Ratios were 4.9 and 6.5 respectively. Immediately following the exam, we reported the preliminary findings to one of our vascular surgeons, and they were as follows: 80 to 99% stenosis in the bilateral proximal internal carotid arteries, and we noted the distal end of the plaque was not well visualized. We also reported greater than 50% stenosis in the bilateral external carotid arteries with normal antegrade flow in the bilateral vertebral arteries. Following our exam, the patient met with the vascular surgeon and he put her on an aspirin regimen for its antiplatelet properties. The surgeon also discussed the options of a carotid endarterectomy with the patient and ordered a CT angiogram for the following day. This was to confirm the bilateral severe carotid disease and to determine the distal extent of the stenosis. In other words, he wanted to know, does the stenosis extend above a level that can be safely clamped during the carotid endarterectomy procedure? The CT angiogram findings reported extensive atherosclerotic plaque in the bilateral common bifurcations, severe stenosis in the bilateral ICAs with at least 90% in the left and slightly less, approximately 80% in the right. The CT angiogram also reported the distal bilateral internal carotid arteries to be patent. What I learned from this case study was that ultrasound, which is an easily accessible, non-invasive, cost-effective exam, is a practical first approach for diagnosing severe carotid stenosis, especially in cases when a physician incidentally notes a bruit on an asymptomatic patient. I also learned that CT angiogram is a helpful secondary exam. It is able to confirm and clarify ultrasound findings, and it's capable of visualizing segments of vessels that may be difficult to thoroughly examine using ultrasound. Therefore, it's especially useful to surgeons in determining if a patient is an acceptable candidate for a carotid endarterectomy. I reviewed my case study with Will Farmer, our lab's chief technician, and Amy Hoggett, one of my clinical instructors. I asked them to point out areas on the CT images which likely helped the surgeon to move forward with his decision to perform the carotid endarterectomy and to explain their importance. So I'll just kind of review those with you guys. Might be a little hard to see, and it's flip-flop because of my camera, but basically you can see here all the calcification, severe calcification, And also on the left, which is here, you could see that really narrow part of the internal carotid artery on the left. That's where the 90% stenosis is likely to be. I also asked what criteria, if any, does a radiologist use to differentiate an 80% stenosis from a 90% stenosis? And I learned that a radiologist uses a caliper to measure the narrowest diameter of the lumen at the stenosis, as well as the diameter of the lumen well beyond the bulb. The measurement of the narrow stenosed area is divided by the measurement of the more distal standard lumen diameter, and then that number is multiplied times 100 to get the percentage. So that's what I learned from my case study. I hope it helped you guys, and I appreciate you for listening. Thanks so much.